organizers of this conference for giving me the opportunity to present before you. This is a topic that is very close to my heart, namely the management of atrial fibrillation, and it's a contemporary review of the same. The objectives of my talk will be: why do you need to manage atrial fibrillation? What are the lifestyle modifications that are important for managing atrial fibrillation? The role of anticoagulation, the eternal debate regarding rate and rhythm control, and finally, some recent literature for management of atrial fibrillation. As we already know via this data, there is significant independent risk for systemic embolism or stroke when patients have persistent atrial fibrillation. Longer the duration of atrial fibrillation, higher the chances of stroke or systemic embolism. In fact, this risk is independent of the use of anticoagulation. Similarly, there is a higher risk of mortality in these patients. This is data garnered over close to 1 lakh patients and comes from mainly randomized controlled trials. Similarly, there is data to suggest that atrial fibrillation has a biological gradient wherein the burden of atrial fibrillation and the stroke risk are present. Therefore, currently the concept is to assess the risk of stroke in these patients with the traditional CHADS S2 VASC score, but additionally consider also the presence of the AF burden. Higher the AF burden, higher the chances of having a stroke. Similarly, in patients who've had atrial fibrillation and a low ejection fraction, review of data suggests that higher the burden of atrial fibrillation, whether the patient has been ablated or not, higher is the risk of all-cause mortality and heart failure hospitalizations. This was data that was derived from patients who had implanted loop recorders for purposes of understanding their AF burdens. We also know that in adults with atrial fibrillation, in a population-based study, atrial fibrillation accelerated functional decline. In these patients, atrial fibrillation was associated with a faster physical function decline, and incident heart failure and stroke perhaps contribute to this over a period of time. As you can see, the confidence interval is very narrow and the beta coefficient per year is minus 0.011. So, this has been the traditional story regarding the management of atrial fibrillation. Anticoagulate the patients, rhythm control and rate control, both of which are similarly good or similarly bad. But this has now changed, wherein rhythm control has started to assume a greater importance as compared to rate control over a variety of substrates, and lifestyle measures have been introduced similar to what roles they play in patients with other lifestyle diseases. The pillars for AF management, so as to say, include stroke risk management, optimizing the modifiable risk factors, and symptom management based on the AF burden, which is done with rhythm control and rate control strategies. This is the 4A management strategy, which allows us to access to all aspects of care for all for atrial fibrillation. This remains a project which requires shared decision making, and not only does it concentrate on preventing strokes and managing symptoms, but it also allows us to treat risk factors and enact behavioral changes. It's equally important to realize that without these behavioral changes, it is very difficult to manage atrial fibrillation. The head to toes algorithm, or the acronym, stands for management of the heart failure, ensuring exercise is done, management of arterial hypertension, diabetes, stopping tobacco, treating obesity, stopping ethanol, and management of sleep and sleep related disorders. Typically, we have anticoagulation, which is given for predicted stroke risk, mainly based upon the CHADS S2 VASC score. This is the most commonest used score, and despite the use of other scores like the ATRIA and the Garfield score, remains the most important one to be used in day-to-day life. However, besides this, it's also important to realize that there is a component of higher AF burden, long duration of AF, the type of atrial fibrillation, namely persistent or permanent, obesity, patients with hypertrophic cardiomyopathy, enlarged left atrial volumes, and poor kidney function, which may independently contribute to a higher stroke risk beyond these scores. The choice of drugs remain NOACs for all patients except patients with mechanical valves and having severe mitral stenosis. Warfarin is to be reserved for unreliable patients for drug consumption or on patients with ritonavir or ketoconazole, especially when rivaroxaban is being used. Dose modification for NOACs, other than those which are present in clinical trials, should have a definite reason. Otherwise, it becomes a placebo for these patients. An important new interaction that is emerging is the interaction of CCBs with NOACs. Use of diltiazem and verapamil seem to increase the chances of bleeding, especially when NOACs are used. Monitoring of NOACs is typically as per the creatinine clearance. You can also monitor as per presence or absence of liver disease and the potential for bleeding. And depending on which of these factors is present and the severity of that illness, monitoring can either be done once in every 6 months or as frequently as once every 1 to 2 months. Proceeding from there to the conundrum of rate control. Currently, rate control is useful when you want to reduce symptoms of atrial fibrillation in an acute setting, when the presence or absence of a clot in the left atrium is not known, when one wants to improve the heart function to assess whether there is the presence of tachycardia-induced cardiomyopathy, give medications to reduce the risk of inappropriate shock, and in patients with cardiac resynchronization therapy, and in tachycardia bradycardia syndrome, along with those having a pacemaker, to reduce the risk of hospitalization. Currently, the role of rate control is present only in patients who are hemodynamically stable, and the preferred drugs include beta blockers, verapamil, or diltiazem. Imidazole is a class 2B indication, as is verapamil and diltiazem when there is decompensated heart failure. Magnesium, when added to AV nodal blockade, seems to have a 2A indication. And whenever a patient is hemodynamically unstable with atrial fibrillation, direct current cardioversion is the choice of management. When there is long-term rate control, for whatever reason, namely in patients with difficult anatomies or in those who have frail bodies or those who had significant side effects to rhythm control or in those who've undergone multiple ablations, medications preferred are the beta blockers and the non-hydropyridine calcium channel blockers. Digoxin still retains a 2A indication for long-term rate control. Verapamil and diltiazem are definitely harmful when the ejection fraction is less than 40%. Cardioversion is a powerful tool to use to restore the rhythm to normal in these patients, and in a nationwide cohort study was found to be significantly safe. It also ensured that the incidence of thromboembolic and bleeding complications was very low, and there was no difference whether NOAC or warfarin was used. Thromboembolism rates decreased from 0.8% to 0.3% when cardioversion was continuously used over this period, suggesting that it is a safe, effective intervention for patients who present with atrial fibrillation when there is underlying hemodynamic instability. Now, coming to the rate versus rhythm control conundrum, factors favoring rate control include older patients with longer history of atrial fibrillation who have large LA sizes with less or no LV dysfunction or less or no AV valve regurgitation. Rhythm control remains the management of choice, especially in patients with a short history of atrial fibrillation, younger patients, smaller left atria, and more recently in patients with significant LV dysfunction and atrioventricular valve regurgitation. This is different from what we used to practice, wherein patients with structural heart disease, shorter history of atrial fibrillation, are more amenable to rhythm control than in those with significantly longer durations, wherein it is probably very late in the natural history of the disease. This is important because the presence or absence of LA myopathy in atrial fibrillation predicts stroke independent of AF burden. And as we remember from the beginning of the talk, persistent atrial fibrillation or higher burden of atrial fibrillation results in a higher risk of stroke independent of anticoagulation. Therefore, there is value in being able to prevent the progression of atrial fibrillation from the more paroxysmal forms to the more persistent forms, as well as prevent the onset of myocardial dysfunction in these patients. LA myopathy happens in a self-fulfilling prophecy form with LA dilation and LA dysfunction, and it is critical for assessment prior to AF ablation, wherein it gives a sense of what the outcomes might be. In the trial that showed equipoise between rate and rhythm control, it's important to realize that over a period of 20 years follow-up, those patients who were randomized to rate control had higher chances of heart failure, lower ejection fractions, and more strokes as compared to those who were assigned rhythm control. Additionally, mortality was high in those patients who developed heart failure. It's important to realize the limitations of this trial, wherein 17% of patients had failed an antiarrhythmic drug prior to randomization. There was a high crossover rate, mainly because of the failure of the antiarrhythmic drug or the intolerance to the drug. There weren't many patients on anticoagulation, and 70% had dilated LA sizes greater than 50 mm, since it was one of the inclusion criteria for the trial. There was also the concept of arrhythmia-induced cardiomyopathy, wherein fast ventricular rates resulted in myopathy in the ventricle, leading to irregular ventricular activation, poorer delta delta, higher delta delta variability in these patients, resulting in reduced LV filling time, thereby leading to increased LA pressures. There is also loss of the atrial kick and the LV filling, resulting in poorer forward cardiac outputs, thereby causing more symptoms and reduced functional capacity. This is the follow-up that we've had for the AFFIRM trial 20 years after the original one, wherein the initial heart failure emergence showed poorer clinical outcomes in patients with atrial fibrillation in this same trial. This suggests that perhaps early institution of rhythm control is critical in preventing poorer long-term outcomes in patients with atrial fibrillation. Now comes the question, how do we control rhythm? The AFFIRM trial was essentially a trial that dealt or had a lot of medication-based rhythm control. And now we have alternative procedural techniques for managing rhythm in patients with atrial fibrillation. Key amongst the trials comparing these two strategies was the Cabana trial, wherein when patients who did have rhythm control did worse when they were randomized to the drug arm as compared to when they were randomized to the ablation arm. So in a head-to-head comparison between patients having catheter ablation and drug therapy as a way to control rhythm in patients of atrial fibrillation randomized to each of these modalities, catheter ablation did have a lower event rate at both 6 and 12 months. It also had better efficacy as compared to drug therapy over close to 4.5 years compared for prevention of emergence or re-emergence of atrial fibrillation. Very critical is the confidence interval in this particular graph, where it's a very narrow confidence interval and well below 1. Catheter ablation in studies also shows a prevention in the general population for the progression of atrial fibrillation over time, which again remains one of the major goals in order to prevent a higher burden of AF, thereby leading to higher risk for stroke. In what I call the AFFIRM trial of this generation, the randomized East AF Net4 trial, where atrial fibrillation diagnosed in the last 1 year with a mean age of 70 years, with 73% of patients having paroxysmal AF, with a mean CHA2DS2-VAS score of 3.4, with 90% anticoagulation coverage, and a median follow-up of 5 years, with a primary outcome composite of cardiovascular death, stroke, hospitalization with worsening heart failure, acute coronary syndrome. It was seen that patients who had early rhythm control with medications or ablation did significantly better as compared to patients who had lenient care or rate control. 75% of these patients were in sinus rhythm at enrollment, and 68% were in atrial fibrillation at less than 1 year. Again, looking at the confidence intervals, these are very narrow confidence intervals, well less than 1. And in patients with asymptomatic atrial fibrillation is where it actually crosses 1, leading us to think perhaps in this group we could be a little bit more lenient. Going from there on to the ablation versus medical trial with the cryoballoon, there was similar decrease in the presence of atrial fibrillation at median follow-up for patients who did undergo cryoballoon ablation for the first persistent atrial fibrillation episode. The hazard ratio again here was 0.25 with a confidence interval that was well below 1. Compare that to drug therapy where they did actually worse. Similar results were also seen with the STOP AF trial where patients with symptomatic paroxysmal atrial fibrillation at a follow-up of 1 year did have lower percentage of arrhythmia reoccurrence with lesser or equal incidence of serious adverse events in the ablation arm as compared to patients on antiarrhythmic medication. The difference was close to 15%. Additionally, it was also associated with a lower rate of AF recurrence when used as compared to antiarrhythmic therapy. And these were patients who were implanted with a loop recorder. As you can clearly see, the cumulative incidence of persistent atrial fibrillation was much lower in patients who underwent an ablation as compared to those who had antiarrhythmic drug therapy. The confidence interval was slightly wider but well below the random mark of 1. Moving on from persistent atrial fibrillation to atrial fibrillation in heart failure. The Castle AF trial was there 3 years ago, but the real clincher was the Castle HTX trial, wherein the study population consisted of patients with symptomatic atrial fibrillation who were end-stage heart failure eligible for transplantation, with ejection fraction of 35%, who had cardiac devices for continuous monitoring. When randomized to first-time catheter ablation of AF versus medical therapy, the data was actually, study was stopped for efficacy. The composite of all-cause mortality, worsening heart failure requiring urgent transplantation or implantation of LVAD was actually reduced by an absolute value of 20% with a hazard ratio well below 1. With a confidence interval well below 1 and a hazard ratio of 0.24. These were patients who had end-stage heart failure eligible for heart transplants. And in them too, ablating the AF resulted in getting off of the transplant list. Now, a different substrate, namely patients with preserved ejection fraction, wherein there was similar reduction, but the numbers were low, and so it remains to be a hypothesis generating thought process. Here too, the peak exercise capacity, the relative oxygen consumption, and the progression of HFpEF at 6 months was much lower in those patients who underwent ablations. Reviewing early AF ablation in the Gloria AF trial, which is a registry consisting of 26,000 patients, there was a 50% reduction in composite outcomes of all-cause death, stroke, and bleeding, with confidence intervals which were lower, and a 55% reduction in all-cause death in these patients. There is increasing evidence comparing early ablation versus medications favoring ablation over a lot of trials in paroxysmal AF2, wherein the mean age is 56 years and the history of atrial fibrillation is less than 1 year. And primary outcome being a freedom from recurrence of atrial fibrillation was close to around 70%. We need to treat 5 patients with ablation instead of antiarrhythmic drugs to prevent 1 recurrence is the pooled analysis outcome of this particular study. When you look at early rhythm control versus rate control in newly diagnosed AF patients. Early initiation of rate control was associated with improved effectiveness outcomes. And these effectiveness outcomes included stroke, ischemic stroke, cardiovascular death, acute coronary syndromes, and heart failure hospitalizations. Additionally, when done early, it also reduced the progression to persistent AF and atrial tachycardia at 3 years. And this was seen more often with radiofrequency catheter ablation, wherein they were 10 times less likely to develop persistent AF as compared to other modalities, namely antiarrhythmic drugs. Even in patients greater than 65 years, they were 4 times more likely when on medications to develop AF or atrial tachycardia. And these were patients greater than 60 with drug refractory symptomatic paroxysmal AFs. What strategy you want to use to prevent the progression is suggested by this trial, wherein use of contact force guided RF ablation decreased the progression to persistent AF as compared to other forms of cryoablation. So, as I said at the beginning, stroke is independently associated with high burden of AF. Prevention of progression of atrial fibrillation remains a key management plan. Lifestyle interventions prevents recurrence and progression of atrial fibrillation, including the development of atrial myopathy. Rhythm control is better than rate control to prevent sudden or other to prevent progression of AF. And in rhythm control, ablation does better than medications. Among ablation, radiofrequency is better than cryoballoon. Even in persistent atrial fibrillation, early as well as late, with an AF history between 1 to 2 years or greater than 4 years, with normal ejection fraction, there was a reduction by merely PVI, perhaps at the cost of higher number of procedures, at being able to prevent recurrence of atrial fibrillation. So, AF ablation, when done in accordance with the guidelines, with the use of current technology, has a low in-hospital complication rate of close to 5.1%, of which life-threatening complications are 0.7%, and shows benefits in preventing the progression to persistent forms of heart failure in those with normal ejection fraction, has mortality benefit in patients with heart failure, and even in patients on transplant list, has the potential to take them off of the same. And these were patients who were ablated according to class 1 and 2A indications majorly. Sometimes ablation may fail, multiple ablations may be done, and still there may be atrial fibrillation. Heart failure may supervene in these patients. Or there may be just a very complicated post surgical anatomy or a frail patient who may be unable to undergo an ablation. Even in those patients, if there is an episode of heart failure with narrow QRS, with permanent atrial fibrillation, with severe symptoms, ablating the AV node and implanting a CRT reduce the risk of death from any cause by approximately 19% at 4 years. The number needed to treat to prevent one death was just 3.7. There was an absolute risk reduction of 27%. So, it's not to say that you need to always ablate, but even in patients where there is inability to ablate, extreme rate control by ablating the AV node, thereby preventing the variance in the RR interval, is also useful. These are the current guideline recommendations. As I mentioned, more LV dysfunction, more AV regurgitation, higher the chance that we need to do rhythm control. Younger the patient, shorter the duration of AF, higher the chance that rhythm control is to be done. In accordance, therefore, AF catheter ablation has a class 1 indication in patients with HFrEF and a class 2A indication in patients with HFpEF. If patients are unable to undergo ablation, AV nodal ablation and pacing in patients with HFrEF is a 2A indication. We can always say that there is criticism to this approach, namely substrate, amyloid versus non-amyloid. What is the role in HFpEF? Do you think the clinical trials are recruiting patients with low risk of progression? Are we using ILR in clinical practice? What is the value of non-clinical AF? And finally, cost effectiveness in a price sensitive society. But what is clear is that there is value in being able to manage rhythm. And as such, if I may say so, since cost is a challenge, perhaps it's better to intervene earlier than to allow the AF to go on for a long period of time before intervening. In summary, therefore, increase in AF burden independently increases the risk of cerebrovascular accidents and heart failure. Oral anticoagulants are critical in preventing strokes. NOACs remain the drug of choice. Rhythm control has mortality benefit in heart failure. It prevents progression to persistent AF. And for rhythm control, ablation is better than drugs. Rate control has restricted use, but ablation of the AV node and implantation of resynchronization devices is a valuable strategy in patients who are frail, elderly, have hospitalizations for heart failure, and in whom ablation may not be possible either because of multiple previous ablations or because of a complex anatomy. Cardioversion to restore rhythm at the outset is a safe and underutilized strategy, and the acronym head to toes is an important acronym to remember for lifestyle management in atrial fibrillation. This is data from a large variety of trials aiming towards early and effective rhythm control. And as such, in all forms of atrial fibrillation, whether paroxysmal or persistent, catheter ablation seems to have value when used early. Thank you very much for your persistent and patient hearing. I'm happy to take some questions in comments or in person. Thank you.